Hello, Overcomers, and welcome to this episode of Connect Over Coffee. I'm Rinsi, the founder of Ovarcom, and today we are joined by a very special guest, Dr. Alejandro Rauh-Hain. So, Dr. Rauh-Hain is a gynecologic oncologist at MD Anderson Cancer Center, and his interests include the surgical treatment of gynecologic cancers and the management of rare gynecologic tumors. He's also interested in research studies conducted in real-world clinical settings to reduce disparities in gynecologic cancer and improve care of young women with cancer. So we have a lot to chat with Dr. Rauh-Hain today, focusing on understanding the disease as well as surgeries in ovarian cancer. So grab your favorite beverage. I have mine, and let's connect over coffee with Dr. Rauh-Hain. And if you have any questions as we go along, please type in the comment sections below, and we will get it addressed post the discussion. And as I always say, please share this information far and wide with anyone who may benefit from all the pearls of wisdom and the insights Dr. Rauh-Hain is about to share with us today. So with that, a huge welcome to you, Dr. Rauh-Hain, to this episode of Connect Over Coffee. An honor to have you with us.
Thank you so much for the invitation. I'm very glad to be here.
Thank you. So we have several questions for you, but before we get into the specifics of surgeries and such, I wanted to just start off our discussion with this question that, we often hear two words in ovarian cancer, right? The stage and the grade of ovarian cancer. So can you tell us about the difference between the stage and the grade, and walk us through the grades of ovarian cancer in terms of how aggressive they can be? And then what should our overcomers know and ask about the grading of the ovarian cancer as they are diagnosed?
Yep. So it's a very good question, and sometimes I understand can be confusing. So stage means how much the disease has spread outside of the ovaries. So typically, roughly, stage 1 means that the disease is localized to the ovary. Stage 2 means that the disease has spread within the pelvis. Stage 3 means that it has spread it to the upper abdomen. And then stage 4 general means that it's spread outside of the abdominal cavity, like the lungs or some of the lymph nodes outside of the abdominal cavity. So that's stage. So stage really helps us understand where the disease has spread outside of the ovaries. And as many of you might know, in ovarian cancer, most patients unfortunately present with advanced stage disease. So typically stage 3 and stage 4, when the disease has spread into the abdominal cavity or outside of the abdominal cavity. Grade is more relates to pathology. So it's more what the pathologists look at the microscope. And traditionally, there have been three grades. There are 3 grades: grade 1, 2, and 3. And I would say that based on a lot of work at MD Anderson, we have tried to simplify the grading system. So for the most common type of ovarian cancer, we now dividing low grade and then high grade. So we are shying away of that grade 1, 2, and 3, and now we divide patients into low-grade ovarian cancer or high-grade ovarian cancer. And that is very important for us because we now know that there are very different diseases. Like patients with high-grade ovarian cancer tend to respond better to chemotherapy, but the prognosis, it's in general worst. And low-grade patients, the cancer doesn't grow as fast, but they don't respond very well to chemotherapy. So we have to treat them a little bit differently. So sometimes we give hormones or other types of therapies, but the prognosis tends to be a little bit better than high grade. So there's one more terminology that adds to the complexity, and that's histology. And the histology, again, it's how it looks in the microscope. And the most common type of ovarian cancer is papillary serous. So that's the most common type. So that's the histology. And then after that, we say papillary serous ovarian cancer, and then we can say it's high grade or low grade. Mm-hmm. And there are other histologies, clear cell carcinomas, mucinous, and other less frequent types.
So, just a couple of questions on what you just shared with us. So, when it comes to the staging, for example, I've been reading some recent articles or publications on the FIGO or staging for endometrial, cervical, other kinds of cancers. So, when it comes to the staging for ovarian cancer, has that changed? The guidelines have changed any, or have they remained what it has been forever? That's question number one. And the number two was, when you talked about the grading, you said 1, 2, and 3 is no longer as much used as they were used before. So now, between the low grade and the high grade serous ovarian cancers that MD Anderson has established, and you are, seeing your patients that way, has that become a standard practice for all hospitals across the nation?
So the first question, so the staging system was updated probably like 4 years ago.
Okay.
And there were not that many changes with the new system. So, probably like around 4 years ago, it was changed. Cervix cancer was changed 2 years ago, and then endometrial cancer was just really recently changed, as you mentioned, like in the last couple of weeks. And now it's very, very complicated.
Mm-hmm.
Ovarian cancer still is a very, I think, simple system. But yeah, have had the same system for the last 4 years. So in terms of thinking about low-grade and high-grade ovarian cancers, I do think that now most institutions have adapted this kind of way of dividing patients, just because the disease, we now understand that there are really two different entities, high-grade and low-grade, that should be treated very differently. So I do think that most places have adopted that, that simplified categorization.
Okay, thank you. So when it comes to surgery and chemotherapy, there is this question about sequence that comes in, right? Which comes first? Is it the surgery or the chemo? And so in your practice and in your experience, tell us how that is determined for each patient, and why does it differ from patient to patient? And is there any correlation between the sequence and the aggressiveness of the disease?
Yeah. So I would start saying that this is one of the most hotly debated topics for GYN oncologists. And at least for the last, 30 years or so. So it's still something that you might hear some GYN oncologists feel very passionate about, whether you should do surgery first or if you can give chemotherapy. So what I would say is that the traditional way that we've done things is to do surgery first. Mm. And the goal of the surgery is to remove as much cancer as we can. And you perhaps have heard the terminology optimal cytoreduction. Mm. And in the past, it used to be like, if we left like tumors less than 2 centimeters, then we changed that to tumors less than 1 centimeter. That was considered an optimal cytoreduction. And now we recognize that the goal of the surgery should be pretty much removing all the visible cancer, so no residual disease. So for many, many years, primary debulking surgery, so primary surgery, was the standard of care. And probably like 15 years ago, there were some institutions that tried to challenge that way of thinking with the hope that giving chemotherapy first, what we call neoadjuvant chemotherapy, trying to shrink the tumor down, then doing surgery, and then after that doing more chemotherapy. So they thought about that kind of like different way of approaching cancer. And in the past, it was reserved really for patients that had like very advanced stage disease, like or that have like a lot of medical issues that it would be hard to do surgery. So it was really reserved for those patients. However, there are now 4 randomized trials. So randomized trials are big, big trials with hundreds of patients in which different investigators have to answer that question. So they have randomized patients to surgery first, or chemotherapy followed by surgery followed by chemotherapy, right? So just changing the sequence. And again, there have been 4 trials run in different countries with a lot of patients. And pretty much in all of those trials, what we know is that those patients that receive chemotherapy first, so so-called neoadjuvant chemotherapy, do not have worse prognosis compared to patients that have primary surgery. So I think the field has changed dramatically. And we look at data from the United States, and I would say that you can see how after the publication of all of these studies, you see the use of neoadjuvant chemotherapy going up. And I would say nowadays in the United States, around 50%, 50% of the patients with advanced stage ovarian cancer, stage 3 and stage 4, receive neoadjuvant chemotherapy.
Mm.
And again, and we've published a lot of those findings as well. So, and this is important because if you give chemotherapy first, right, you shrink down the tumor.
Yeah.
So the surgery is not as complex as if you do surgery first. So how often you have to remove parts of the bowel, the spleen, or do other complex procedures is much lower if you give chemotherapy first. Mm-hmm. So if you have less complications and the same survival, then that's why a lot of people have now pretty much adopted using neoadjuvant chemotherapy.
So follow-up questions on that. You said that it's the similar survival, statistics. So when you say similar, I mean, so then it becomes like a choice by the provider or the healthcare team as to, because if there is the end result is pretty much the same, whether you do the chemotherapy first or the surgical procedure first, then it becomes a choice of the healthcare team and or the patient. So my question here is, how much are the patients involved in the decision-making process? Because if, like I said, if the end goal or the end result is the same, it is really a matter of preference then, which one do you want to tackle first? So how are the patients empowered to make those decisions along with the healthcare team?
That's a very good question.
First,
yeah, that's such a good question. And you're absolutely right. I do think that the question of whether doing surgery first or neoadjuvant chemotherapy, there's a lot of philosophy in terms of institutions. Like you might go to an institution in which they are more pro primary surgery, or you might go to an institution in which neoadjuvant chemotherapy has been more widely adopted. So yeah, I mean, I think big part of the decision is how the surgeon feels about whether they can resect all the tumor and whether they feel that surgery is in the most benefit for the patient. But in all of this, I do think that we are, like, the patient's voice is very, very, very important.
Exactly.
Like, very, very important. And I would say that in my practice, I always say to the patients, there are these two ways of doing surgery. If I feel, based on the imaging or doing a diagnostic laparoscopy, meaning that we put a camera inside during surgery and we look around. So if I feel that based on my assessment of the imaging and assessment of a diagnostic laparoscopy, that I can remove all the cancer and I leave no cancer behind, I would do a primary surgery. And if I don't think that is the case, or there are a lot of comorbidities, or there's something else that precludes of going having surgery, I would start with neoadjuvant chemotherapy. But I'll present it to the patients as two options, and definitely we can talk about it. And I have had patients definitely that feel more inclined to have one or the other procedure, and that's fine, and we can talk about it. And if I feel that it's worth at least attempting by looking with a diagnostic laparoscopy, I would do that for sure.
And thank you for sharing that, because MD Anderson, as we know, it's a big center, it's an academic center, but majority of our overcomers are probably being treated at community setting hospitals where these kinds of conversations probably don't happen as much. So it is in our interest to empower our overcomers to ask these questions, that what are the two options and what is the end result of these two, so that they can also make informed decisions as to what works for them at that point in time after getting diagnosed. So thank you so much for sharing that. So now, in terms of the different types of surgeries, right? So what are some of the types of surgeries that are considered in the treatment process based on the subtypes of ovarian cancers? And typically, and you answered this question just a little bit, that the which subtype responds the best to surgeries and which one doesn't? And what is your game plan on that, generally speaking?
Yeah, you're asking very good questions. So, very advanced questions. So, I would say that for the high grade ovarian cancers, because they respond to chemotherapy more often, I think we feel more many times we don't mind about giving neoadjuvant chemotherapy, then surgery, and then more chemotherapy. Low grade ovarian cancers are very different, as I mentioned before. They really don't respond very well to the traditional chemotherapy. So in many instances, if a patient has low-grade ovarian cancer, we really try to do surgery, as if possible, right? If someone has, unfortunately, a large burden of disease that we think that surgery is not, we're not going to be able to do much, then those patients we try to give neoadjuvant treatments. But I think that we tend to be more aggressive for patients with low-grade ovarian cancers, even in the situations in which we think that we may leave some cancer behind, because we know that chemotherapy might not work, and these patients tend to be longer. So if you can try to remove as much of the cancer, you can prolong life significantly. So yeah, I mean, I think there is a different paradigm between low-grade and high-grade serous ovarian cancers. There are other histologies. There might be some subtleties. So for example, for mucinous ovarian cancers, they behave more like gastrointestinal cancers. So for example, in our institution, we have a protocol that we treat them like if they are like if they are gastrointestinal cancers. So the histology really can help us decide what is the best approach in terms of surgery and chemotherapy.
Okay, thank you. So in your experience, and you have done so many surgeries by now, right? So in your experience, what have you noticed to be the biggest questions or the concerns for our overcomers that pop up in their minds prior to surgery? And how would you provide your guidance to address those primary challenges that patients and family members feel during or before the surgical process?
Yeah, I think the first question is always whether we're going to do surgery or give chemotherapy first.
Yeah.
I think that, and as I mentioned before, I would say that now with 4 large studies, we feel more and more comfortable giving more neoadjuvant chemotherapy. So that used to be a question that we used to get a lot. People still ask, and we address those issues. So I think that is the first question that I would say we try to address. The second thing that it's important is just setting up expectations about the surgery. Most surgeries are done open, so it's like a big incision, in which we remove the uterus, the ovaries, something that we call the omentum. That's just a fatty layer that it's very common that the cancer spreads to that area. And then many times we have to do surgery in other organs. So if there's cancer in the diaphragm, we have to resect that. If there's disease in the spleen, we have to take out the spleen. And many times there's disease in the bowel, either the small bowel or the large bowel, and we have to resect that. So many times, and this is something that we talk to patients before we go to surgery, is that we have a plan, and based on the imaging, we have a sense of how much we are going to have to do, but imaging is not perfect. And many times we open and we find out that there's more cancer than we were anticipating, and we may have to do more procedures. So I think for patients, it's important to know that every time that we go to the OR for the bulking procedures, that there is a risk that you have to do more than what you were anticipating initially. Yeah. And part of that is doing bowel resections. And, bowel resections can have complications. So there's risk that you may have to do additional procedures if you end up doing bowel resections and so forth. So I think it's important for patients to understand those risks and expectations about that. They usually are going to be in the hospital for 3 or 4 nights if everything's fine, but they might have to stay a little bit longer if there are complications, and that the recovery takes around 4 to 6 weeks. But what it's hard for the patients that have these procedures is that as soon as we know that they're ready, we're going to restart chemotherapy. So they're never going to be 100% back to normal, right? So for patients that undergo surgery outside of cancer that we don't have to give chemotherapy, the recovery is 4 to 6 weeks.
Right.
But if you have to start chemotherapy, that's always, that step of moving to chemotherapy, it's always challenging. But I think that's the mindset that they have to have before going surgery, understanding that after surgery, we still want to give more treatment.
So, just as you were talking, I was thinking, even from a psychological point of view, if you have already done 3 chemos before, you're already kind of in the process, right? And then you do the surgery, and then it's not as bad because you have only 3 chemos left. I mean, just generally speaking, right? But now if you do the surgery up front, then you have the whole journey of chemo left after the surgery. Just a way to look at it, I guess. Certain patients will feel that I want to do the neoadjuvant just because, even from a psychological standpoint, it seems less. That
you can divide it up into that's a good way to. I mean, I think that's an interesting way to see it. But yeah, absolutely. I would say that it's, and we happy to talk about chemotherapy. I would say that to me, like what I've seen the patients do the best with chemotherapy is the mindset. Yeah. So if someone goes in understanding that it's 6 cycles of chemotherapy, they're going to be fine. They try to work, they try to have their normal life. I do think that those are the patients that tend to do the best than patients that are not as active. Obviously, there are a lot of different things that come into play, but I would say that absolutely mindset has significant effects in recovery and how the people, patients deal with chemotherapy, how they deal with surgery.
100%. I mean, just life in general, right? I mean, the power of the mind, we have not even unlocked, I would say 25% of it. So, I mean, well said on that. So now, there's this radical versus the simple hysterectomy, right? And so I understand there's some debate out there and on the radical versus the simple. And how do you determine which patient meets the criteria for one versus the other?
Yeah, I think the debate about simple versus radical hysterectomy is more for cervix cancer than it is for ovarian cancer. And cervix cancer, it's different disease. And sometimes in patients with ovarian cancer, we have to do a radical hysterectomy just because of how the tumor it's distributed in the pelvis. But that is more a technique thing when you have to remove the tumor rather than something that we have to do based on pathological findings and so forth. So really the difference in general between a simple and radical hysterectomy in patients with ovarian cancer is just a matter of being able to resect all the tumor. And I would say the majority of the times we do a simple hysterectomy rather than a true radical hysterectomy in patients with ovarian cancer. But that debate between simple and radical hysterectomy is now more relevant from recent data in cervix cancer.
Okay, thank you. So there are many, we understand there are many post-operative issues that some of the things that you just mentioned that happens for our overcomers, whether it be, physiological, emotional, logistical, it could be anything, right? So in your guidance as a surgeon, what would be your guidance to our overcomers in trying to reduce all these post-operative issues that may arise? And, what should our overcomers be aware of?
Yeah, so a couple of things. So there are things that patients can do before surgery and then during recovery. So before surgery, question that we get asked all the time is whether diet has to change or not. And I would say that I don't tell patients to change their diet much. I would say just try to be as healthy as they can. That is the most important thing. Obviously, if someone has issues with nutrition, that is a separate thing. And then we usually involve our nutrition experts around, but that is if someone has issues with that. And that is not a very common thing initially with our patients initially. Second thing is, for sure, if someone is smoking, stop smoking. And the other thing is that if there are comorbidities such as diabetes, so making sure that diabetes is under control, their blood pressure is under control. So try to optimize the health overall health before undergoing surgery. In terms of recovering from surgery, like as I mentioned before, usually patients spend 3 or 4 nights in the hospital, as long as everything goes fine, and there's always the risk of complications. And most of those complications, it's difficult to anticipate. So things might happen by surprise. So your physicians and healthcare team will be vigilant for those things, but just keep in mind that other things in surgery might arise, and most of them are unpredictable. In terms of recovery, as I mentioned before, it takes like 4 to 6 weeks to feel back to normal. But in that time frame, it's very likely that your team will start the chemotherapy. So sometimes it's very hard to go back 100% to normal. But we try to wait as much as we can before we start chemotherapy. But in general, we don't like to wait more than 6 weeks to restarting the chemotherapy. Many times for patients that have open surgery, we recommend taking blood thinners after surgery. So it's very likely that your medical team will give you some kind of medication to prevent blood clots. So very important that you take those, just because we want to avoid, issues with deep venous thrombosis with clots that can be fairly dangerous, and that happens more with patients with ovarian cancer. And the other thing that we get questions a lot is pain management. And everyone is different, and every patient has a different pain tolerance. I have had patients that take very little pain medication, or they don't want to take any pain medication, and others that require more. I would say that my philosophy is that take enough to be comfortable for the first couple of days. And for the first couple of days, take the pain medication around the clock, the first 2 or 3 days when you're at home. And then after that, you can start tapering down the pain medication. But different institutions might have different strategies or protocols how they manage their pain medication. So just follow that. But just it's important that you have a good sense of how they're going to manage the pain, and that you're comfortable enough that you can start moving around at home. And the other thing is, I think a lot of patients are afraid of moving around after surgery. I would say that unless there's a significant contraindication, and that's something that your healthcare team will tell you, we try to ask patients to start moving pretty soon after surgery. And also when they get home, we ask them to be active. There's no really rules about that. So just your body will tell you if you're doing too much, and you're going to feel very tired, and you know when to back down. The most important thing that we ask patients not to do any heavy lifting, just because if they have a big incision, they can have a hernia. But it's a lot of common sense, and everyone's a little bit different. But start moving around as much as you can, and if you feel very tired at the end of the day, that's your body telling you maybe to stop, not do that much, and then just take a break.
That makes sense. And so in terms of, the post-operative issues, you talked about a lot of the things that just to tackle them. And so thank you for that guidance. So in terms of complications, though, I mean, we touched upon it, but in general, I mean, what are the complications that could arise, which could lead to a readmission to the hospital, or a longer length of stay, or even like a operation or surgery? I mean, these are extreme situations, but it's, as we are learning more about this, it's good to know. I mean, what are some of the complications that we should be watching out for, and what should our overcomers know and especially be aware of when they are preparing for surgery in the near future?
Yeah, so complications from during surgery or after surgery that we usually talk to patients about is during surgery, there's always a risk of bleeding. Okay. So sometimes some patients might require blood transfusions either during surgery or after surgery. Okay. The other big one is infection. Yes. So there's risk of having an infection on the incision, or having an abscess or a collection in the abdomen. Yeah. Many times we can treat many of the infections with antibiotics. But if there's a collection or an abscess in the abdomen or somewhere after surgery, you might need to have a drain in place to drain that infection, plus antibiotics. And there are different types of infections as well, not only infections from the incision or in the abdomen. You can have a lung infection like a pneumonia. You can have a urinary tract infection, or there are other infections that can happen, and there are different antibiotics that we can use depending on the bug that we find and so forth. But I think infections, I would say, happen between 2 and 5% of the times.
Oh, that's not bad. That means majority of the cases
Yeah.
it isn't. That's good to know.
It really varies widely in how long was the surgery, how complex was the surgery, whether the patient has comorbidities. There are many risk factors, but the majority of the patients don't have
That's good.
like significant infections. The other risks that can happen that we talked about is having clots,
Yes.
either in your legs or the clots in your legs can go into your lungs, and that can be very dangerous. So we use blood thinners after surgery to prevent that. And then after surgery, there's always the risk if there's a major complications that we have to do other procedures. So sometimes we have to go back to the operating room to fix things that we could have injured during the operation. So there's always the risk that you may have to go back to the OR. I would say that happens not that commonly, but that's obviously a risk. Or that the interventional radiologists have to put drains or other things to fix issues that might arise. Other things that can happen after surgery is annulus. So it just takes time for the bowel to start working after surgery. So nowadays, we actually feed patients soon after surgery. In the past, we used to wait until patients passed gas to start feeding them. But we now know that if we feed patients soon after surgery, that makes the bowel start waking up earlier.
Right.
So, but sometimes in some patients, especially with big operations, the bowel might take some time to wake up, and that's called annulus, or the extreme form is a blockage on the bowel. Most of the times, we can treat those with a tube in the nose that goes into your stomach. And very rarely we have to go back to the OR to fix the obstruction. But most of the times the ileus, that slowing of the small bowel, it just resolves on its own.
Thank you. That was a lot of good information. Thank you for sharing. So, minimally invasive surgery seems to be the catchword for the day, right? So, what does minimally invasive mean, and who, again, is the best candidate for this type of surgery?
Yeah. So minimally invasive surgery means that we can do the operation with small incisions and using a camera. And there are essentially two ways to do it. One is what we call straight stick laparoscopy. So that's like the old-fashioned way in which we use a camera and we use instruments and we can do the operation that way. And nowadays there's robotic surgery, like the Da Vinci robot, in which the surgeon sits in a console and then can manipulate the robot to do the operation. So those are really the two ways to do minimally invasive surgery. Different programs, they have different trainings. I would say most GYN oncologists are used to doing robotic surgery. But in my mind, I can do robotic surgery, and I can do both, and I actually do more straight stick laparoscopy, because that's how I train, and that's what I've been doing for years now. But at the end of the day, the reality is that either way is the same as long as the surgeon feels comfortable doing it.
Right.
There's some controversy. People feel that robotic surgery might be better, but the reality is that it's just a tool, and as long as the surgeon feels comfortable, honestly, I think it's the same. For the patient, I mean, the surgeons might have different preferences. So who are the best candidates for laparoscopic surgery? So I would say that if a patient has what we presume early stage ovarian cancer, so meaning that they have only an adnexal mass and the disease has not spread outside of the abdomen, many GYN oncologists or surgeons might feel that they can remove the ovary and do the complete staging. So staging means taking biopsies of the different areas, particularly the lymph nodes and the omentum. So as long as they can feel they can do that through laparoscopy, that seems reasonable. The data that exists is not very robust. It's all based on observational data that has a lot of limitations. But I would say that in general, we feel that laparoscopic, doing these procedures of staging, laparoscopic or open, really are the same as long as the surgeon feels comfortable doing a very thorough assessment and a very thorough a dissection to assess for a spread of disease.
Thank you for walking us through that. So,
So, sorry, just to interrupt, like for advanced stage disease, it's a completely different story. And I would say that right now for advanced stage disease, either for primary surgery or as an interval after neoadjuvant chemotherapy, it's experimental.
okay.
We are running a big trial at MD Anderson in which
That was
we are
going to be my next
sorry.
question. No worries.
Okay.
So I was actually going to ask you that you're
Sorry.
doing a lot of work on the role of the minimally invasive surgery, and no. So my question was going to be twofold. So basically, what I was going to ask you is, for the minimally invasive surgery, you have been involved in that work, which shows for cervical cancer, which showed that it actually may promote recurrence. And it's not really the best way to do surgeries in cervical cancer. So how does that reflect for ovarian cancer? And I know that you're doing a lot of work in that space as well. So please share your thoughts on what our overcomers should know, and also just shed a little bit of light on the cervical cancer, also why this was not the best way to do it, and why was the prognosis actually worse in this case?
Yeah. So in cervix cancer, for a long time, we thought that doing these radical hysterectomies that we were talking about for cervix cancer was safe to do laparoscopic. And there was a lot of data from different institutions, including data from MD Anderson, that suggested that it was safe to do it.
Yeah.
The problem was that all of that data was based on observational data. That means the data that was collected kind of going back, and it was not based on truly randomized trials that provide the best level of evidence that we have. And although all of those prior studies had a lot of issues, but we all thought we're very good laparoscopic surgeons. There shouldn't be a difference between doing laparoscopic or open. So in 2018, there was a big randomized trial that was run by MD Anderson by my colleague Pedro Ramirez, in which he showed in a randomized trial that patients that had minimally invasive surgery for cervix cancer had worse survival than those that had open surgery. Mm-hmm. And at the same time, we published a very well run retrospective observational study pretty much showing the same thing. And both papers were published in the New England Journal of Medicine. And that led to a lot of controversy and a lot of surprise in our field, because it was hard for us to believe that laparoscopic was leading to worse survival. But after that, really other studies have confirmed those findings. So what it's important is that, again, the best evidence that we can provide is from randomized controlled trials rather than observational studies. Having said that, there are sometimes that we cannot get data from randomized trials. Randomized trials are very expensive. They're very complicated to do, and they can take very, very, very long time to do, right? So sometimes we have to rely on not great information to provide, information to patients. So that's why kind of this evolution happened with cervix cancer. So with that in mind, we started looking at the question of using minimally invasive surgery for ovarian cancer, this like 7 or 8 years ago. And we have looked at the retrospective data, like this not perfect data, and we have seen that it seems to be safe to do laparoscopic surgery after neoadjuvant chemotherapy for patients with ovarian cancer. And we've done a couple of studies. There are other institutions that have shown similar results. But again, it is not the perfect data, and it's not a randomized trial. So really to try to confirm that it is safe to offer minimal invasive surgery, we are now running a large randomized trial, and we're hoping that in the next 5 years we're going to have the results from that trial. So what I would say is that if you receive neoadjuvant chemotherapy, your surgeon or GYN oncologist might offer you minimal invasive surgery. It seems that based on this not perfect information that it's safe, but we don't know that for sure. So I do not offer minimal invasive surgery for my patients outside of a clinical trial. Mm-hmm. But again, you might hear different opinions from your surgeon or GYN oncologist, but it's important to bring these issues up, because even though that it seems to be safe, we're not sure. And we already had a kind of an unusual surprise from what happened with cervix cancer.
So this is a really important point that you raised, that the neoadjuvant option with the minimally invasive is something that you mentioned that you would not consider it for your patients that are outside of clinical trials, right? And so it's important for our overcomers to know and understand that if their surgeon were to propose a minimally invasive after the 3 rounds of chemotherapy, then that's one of the questions to ask, that where is the data, what are the numbers, what is the statistics, if this is not in the scope of a clinical trial, because the results and the study is still ongoing, to what you just said. So
exactly.
In terms of recruitment, then, are you still recruiting patients for this particular trial? And if so, how should our overcomers, like interested overcomers, sign up for this clinical trial?
Yeah, so we just completed the first part of the study. So the first part was the first 100 patients, and it was just to make sure that we could do the actual trial. And we found out that doing laparoscopic in a prospective way, so looking forward with very thorough collection of the data in a controlled environment, it's doing laparoscopic surgery safe. And in the short-term outcomes, it doesn't seem to be worse than doing open surgery. Again, short-term outcomes, right? We don't know whether doing minimal invasive surgery leads to faster recurrences or worse survival. So we won't know that until we finish the trial. But at least in the short-term outcome seems to be the same. So we get enrolled right now of today, like 115 patients. The hope is to enroll 580. So we have long ways to go. The trial is open right now in 12 institutions. The trial is run in the US, but also Canada, Brazil, in Italy, the Netherlands, and we're hoping to open more sites in the future. And there are at least 8 sites in the United States in which the trial is open.
And so the patients can just go the route of finding the particular trial that you're talking about and then signing up. And by the way, I mentioned this is in one of our episodes. Now, Overcome has a clinical trials website. I mean, we are housing clinical trials on our own website, so you don't have to go to clinicaltrials.gov to search for ovarian trials. You can just go to this is my message to the overcomers and audience listening, that you can go to our website, you can search for clinical trials in a friendly, direct, simple manner, and search for all the clinical trials that make sense for you, and to apply for the ones that you are interested in. So then, in terms of the unmet needs in surgical treatment of ovarian cancer, because we have made a lot of progress, but we all know that we have a lot more to do and more miles to go, right? So in terms of unmet needs in surgical treatment of ovarian cancer, what would be your vision to see, and how would you like to see that addressed and in the near future?
So just before I forget, the name of the trial, if you're interested in participating, it's called LANCE trial,
Thank you.
LANCE, LANCE trial. So controversies for ovarian cancer. So despite 4 randomized trials, I would say that there are still GYN oncologists that feel very strongly that we should do surgery first and not do neoadjuvant chemotherapy. There's actually now a 5th ongoing study. It's called the TRUST trial. And that is being run in institutions that are very surgically aggressive. So the only site in the United States is Memorial Sloan.
I was going to say it has to be Sloan Kettering. Okay.
Memorial Sloan, and then there are other sites. Many sites in Germany are participating. So we are waiting for the results from the TRUST trial, and I would say that if the TRUST trial shows that neoadjuvant chemotherapy does not lead to worse prognosis, I'm hoping that is going to be, the resolution of this controversy in our field. Mm-hmm. If it's a positive trial, then I think we're going to have to go back to the drawing board and figure out what we're going to do. So, but I think as of now, I mean, the 4 randomized trials that we have seem to be very definitive for the majority of the places. So I think that is one controversy, but again, the TRUST trial will shed some light into that specific question. I think, as we talked about, minimal invasive surgery, something that I'm very passionate about. The LANCE trial hopefully will help us decide whether we can offer laparoscopic surgery for patients that receive neoadjuvant chemotherapy, and who are the good candidates for laparoscopic surgery. The benefits from laparoscopic surgery is faster recovery, less complications, less time in the hospital, receiving chemotherapy much faster. So, and then cosmetic as well. You don't have to have a big incision. So I think that is something that, I think eventually is gonna become a bigger question as we keep doing more and more neoadjuvant chemotherapy. Other interesting questions that I think are going to happen in the future is, as we do more neoadjuvant chemotherapy and we see patients that have good response to chemotherapy, and now that we are perhaps using more PARP inhibitors like other therapies up front, that there might be patients that have complete response to treatment before doing any surgery, right? So there has been this theory in the field about perhaps if you do complete response to therapy, I mean, are those patients really just need any surgery or just a very small surgery to take out the ovaries and the omentum, or what is going to look like? I would say that's a very difficult question to answer, and I don't think in the next 10 years, we're going to have that answer. But I think the bottom line is that it seems that the field is moving towards less radical surgeries, perhaps, as the therapies continue to evolve and continue to improve.
Wonderful. Thank you so much. And so, I have asked you a lot of questions. We have talked about a lot of topics and interesting things about surgery. So what have I missed asking you that you would like to fill in the blanks?
So I would say, I think I mentioned this before, but it's having a new diagnosis of ovarian cancer, it really changes patient's life, the family's life. It's very, very, very challenging. I would encourage all the patients and family members to ask all the questions. Never, ever be afraid of asking questions. That's, all of us that, dedicate our lives to taking care of patients. That's why we are there, right? So never feel afraid of asking questions. And if something doesn't make sense, just ask why your surgeon or your GYN oncologist, your medical oncologist is deciding to do whatever they're deciding to do. And very likely they are doing and making the decision for your best interest. But it's important to know why they're doing it. So never ever feel afraid or shy away of asking questions. And do understand that it is very, very hard, but having the right attitude and the mindset really, really helps. And I think all of us have seen patients that come with the right mindset and within the situation act very positively. And I think in my experience, those are the patients that tend to have not as a rough time as others that are just thinking about what's going to happen with the chemotherapy, the nausea, and so forth, and the potential complications. So I do think that for family members, for patients, having that attitude of, trying to beat the cancer and having the best attitude possible, I do think that's, that is the best way to go. And also, there have been dramatic changes in ovarian cancer in the last 5 years. For many, many years, we only had like chemotherapy to treat ovarian cancer. We now have PARP inhibitors. There's the potential use of immunotherapy or other more advanced types of therapy. There's a lot of research going on, but really there's been a big, big change and a lot of steps moving forward in the management of ovarian cancer. So don't be afraid to ask about clinical trials and look around. I think it's important.
Absolutely. And I will just even add, in certain cases, we have talked to many of our patients and overcomers where they have shared with us that, simple things like genetic testing, simple things like, the availability of clinical trials, etc. These are not really communicated uniformly across institutions, even across states and in the country or even beyond. So it's important to empower our overcomers to know that, ask about genetic testing, ask about clinical trials, ask about even second opinions, because it's important that you are comfortable, like you said, that's the word you used in one of your answers, that you are at peace and you are comfortable with your treatment plan. That is the most important thing. So as many questions as you need to ask to get there, it's important to do that. So perfect. Fantastic conversation.
Just want to add one more thing, because I
No,
think
this is my question to you, where you can add that, because I was going to ask you what message of overcoming would you like to share with our audience, and I feel like you're going to answer that.
Yeah. So just because you mentioned genetic testing, and so that's something that I'm very passionate about. So every patient with ovarian cancer should have genetic testing, or for the most common histology, should receive genetic testing. And this is very important for two things. One is that we can help decide what therapy you might be eligible for. But the other important thing is that if you have a BRCA mutation, or less likely Lynch syndrome, but the most common is BRCA mutations, that means that your close relatives have a 50% chance of having that mutation. And there are a lot of things that we can do to prevent cancer in your family members. So if you have ovarian cancer and you have not had genetic testing, you should definitely get a genetic testing. And for those patients that know that they have a BRCA mutation, or they find out that they have a BRCA mutation after undergoing genetic testing, very, very, very important that you talk to your family members, because they also need to be tested, because they have, again, 50% chance of having the mutation. And if they have the mutation, we can do prophylactic surgeries to prevent cancer. We can offer imaging. We can offer a lot of screening options to try to prevent ovarian cancer and other cancers. So very, very important. So I think that, to me, is a big, big message, and something that I think we can do a much, much better job.
Wonderful. So just in closing, just a very positive, vibrant message. What would you like to share with our audience that's listening today?
Yeah, I think there's been big changes in ovarian cancer. We really have moved the needle in terms of the treatment, and we're hoping that eventually we're going to be able to cure more patients with ovarian cancer. We now have data from PARP inhibitors in patients with BRCA mutations that potentially we are curing a number of patients. We don't know for sure, but it seems that the data suggests that we're curing patients. And 10 years ago, that would be something that all of us would be shocked. Right. So again, we little by little we're moving the needle, and eventually, hopefully, we're going to cure more patients. So I think there's always hope, and I think we have to be positive and just keep moving forward.
Wonderful. Thank you so very much, Dr. Rauh-Hain. This was a fabulous conversation. We learned so much from you, and thank you for your time and walking us through all the options, all the challenges, and the guidance for our overcomers when it comes to surgeries and just in general, their disease state. So we thank you for your time, and overcomers, thank you for watching this episode of Connect Over Coffee. I know that I always say that we keep learning from these experts so much. So please share all this great information far and wide with anyone you think may benefit from all the pearls of wisdom and the great insights that Dr. Rauh-Hain shared with us today. And we will be back with the next episode of Connect Over Coffee very soon. Until then, you keep overcoming. Thank you and bye.